Before I start, I would just like to take a few minutes to tell you about how I came to decide on the topic I'm about to discuss today. So during residency, I was already interested in pediatric urology, and I decided to pursue this fellowship after several consults involving children with complex urologic pathologies, both in private and government hospital practice. It was unfair managing these patients without formal specialty training, so I had to refer them to the capital where the pediatric urologists are concentrated. But transport is always an issue due to the distance, not to mention the very long wait list for outpatient consults and surgeries. And when it comes to pediatric urology, I became curious about transitional urology. My mentor back at home would always mention that this new subspecialty must be given importance, especially now that a lot of new urology graduates are going into pediatrics. Our situation in the Philippines is very much different compared with what you have here in Canada, as we continue to struggle with the lack of universal healthcare and most services are still obtained with out-of-pocket money. But there are efforts to hasten the decentralization of our healthcare system and the situation is getting better, albeit slowly. We hope that the care for these children with congenital abnormalities will continue to improve and that more of them can reach a period of transition. Until such time, it is good to be prepared and be informed of the essential elements of this growing field from the people who first took the initiative. I believe that there are more qualified and competent local and international speakers who have already discussed congenital lifelong urology with this audience. Still, I tried to organize this lecture to re-emphasize its importance, highlight recent advancements in this field, and give you second-hand updates about transitional urology status in BC. Is my PowerPoint presentation clear to everybody?
Yes, we can see your slide.
Okay. So I'll start by presenting an 18-year-old female born with cloacal malformation and sacral agenesis in the context of bacterial association, a solitary left urinary collecting system, and a neurogenic bladder. Oops, sorry. She underwent multiple procedures since birth, including encolostomy at 3 hours of life, pyeloplasty and ureteral reimplantation, bladder augmentation, and mitrophan of appendicovesicostomy at 12 years old to facilitate bladder emptying, clubfoot correction, resection of bilateral Mullerian remnants, repair of bladder cloacal fistula, multiple bladder and upper stone surgeries for recurrent struvite stones, and a recent spine surgery for congenital scoliosis. She had a total of 43 procedures in her lifetime. And now, she's currently having recurrent UTI with significant stone burden on the solitary left kidney. Given her age, we are in the process of transitioning her to our adult urology counterpart. Such is a representative patient who is in substantial need of transitional urologic care. The objectives of this lecture are to discuss the salient issues that arise when patients with congenital urological disease transition from pediatric care to adult care, present the status of transitional urology described in different studies, and enumerate recommendations available in the literature that can be applied to help set up a transitional urology clinic. Before it came to be known as congenital lifelong urology, this relatively new specialty was previously associated with terms such as adolescent urology, transitional urology, or isovial urology, as was mentioned by Dr. McNeely a while ago, coined by Christopher Woodhouse, who is considered to be the father of adolescent urology, from the term isovios, which is Greek word for lifelong. It was emphasized in his article that since babies with major congenital anomalies of the genitourinary tract have all embracing holistic care during childhood, they should require the same level of care in adult life. This is supposed to be the role of congenital lifelong urology. There have been significant improvements in treatment that led to marked increase in survival of children with congenital diseases, almost all of them reaching adolescence and young adulthood, which are considered times of physical, psychological, and social change. However, the children who graduated from pediatric care are compared to an orphan population because of the rarity of their conditions. They comprise a small proportion of the population that it is difficult to justify channeling a hefty number of resources to this field and setting up transitional clinic from an economic point of view. Many children with conditions such as posterior urethral valves, bladder extrophy epispadias complex, VUR, prune belly syndrome, myelomeningocele hypospadias, TSDs, cloacal malformation, and cryptorchidism will require continued urologic monitoring and/or treatment into adulthood. There are 4 main urologic goals for these individuals. The first is the preservation of renal function. Worsening renal function during puberty and young adulthood coincides with a time when patients are at greatest risk of being lost to medical care due to an unsuccessful transition. More often, regular surveillance with serum creatinine and renal ultrasound are discontinued for several reasons, hence inadequate monitoring of asymptomatic renal deterioration. The second goal is optimization of lower urinary function to manage urinary incontinence for social acceptance, minimize complications from prior procedures, and have access to surgical intervention if the need arise. Surveillance of lower urinary tract symptoms is also critical in identifying a more serious de novo pathology, such as worsening lower urinary tract function in a young adult with myelomeningocele, which may represent a tethered cord. Moreover, worsening lower urinary tract function in a young man with posterior urethral valve may represent decreased concentrating ability of the dysplastic kidneys. The third goal is appropriate monitoring for associated malignancy if necessary. And the last goal is preparation for the sexual and reproductive aspects of adult life. In individuals with congenital anomalies of the genitalia, post-pubertal anatomy can potentially affect or limit sexual and reproductive function. With hypospadias, for example, dissatisfaction with phallic appearance is reported in 20% to 30% of patients and is most commonly related to concerns about penile size and residual chordee. Similarly, in adult men with extrophy, penile size and dorsal chordee were reasons given for unsatisfactory sexual intercourse. Going back to the index patient presented, we can see that all 4 aspects are needed to be addressed for a patient with cloacal malformation. Before proceeding to the discussion of congenital lifelong urology per se, I'll just take a few moments to briefly discuss the problems of the index patient with cloacal malformation. Patients with cloacal anomalies and anorectal malformations have multiple reconstructive surgeries as infants and children, which can have a myriad of effects on the urinary tract. Typically, the genitourinary and gastrointestinal tracts are joined at birth and require surgical separation in infancy. Given both the congenital and iatrogenic insults incurred early in life, most patients with cloacal anomalies require lifelong monitoring and treatment for both bladder continence and compliance. She underwent augmentation cystoplasty, which can create metabolic disturbances, vitamin B12 deficiency, and bone demineralization. In a decade-long retrospective review, more than 1/3 of patients will require further or revision surgery following augmentation cystoplasty. The indications for reoperation included bowel obstruction, bladder stones, and bladder perforation. In bladder augmentation with a continent abdominal stoma, there is a 50% incidence of bladder stone formation within 5 years of surgery. Surveillance strategies were also described for reservoirs containing bowels, since there was a documented increased risk of infection and malignancy. Finally, it has been pointed out by Levitt and Peña that the length of the common channel can also have significant impact on surgery and outcomes. Patients with a channel of greater than 3 centimeters have a higher incidence of urological anomalies, often require more complex surgery, and have a higher risk of poor functional results when compared to patients with a channel of 3 centimeters or less. Congenital solitary kidney belongs to the umbrella group of CACUT, or congenital anomalies of the kidneys and urinary tracts, which constitute most causes of CKD in children. Hence, prompt nephrology consult is often instituted and transfer to an adult counterpart is necessary because of the significant association with a higher risk of dialysis compared to other Kakut entities such as renal dysplasia or multicystic dysplastic kidney. As for her partial staghorn renal calculi, treatment should follow the same guidelines and principles as for normal kidneys, with slight but necessary modifications conforming to the altered anatomy as a result of her previous operations. Sexual and reproductive functions are often overlooked, not just for cloacal malformation patients, but for transitional urology patients in general. A study by McCloskey and colleagues showed that 54% of male patients and 21% of female patients visited the transitional urology clinic due to insufficient information about sexuality and fertility. There are multiple potential barriers, including lack of knowledge and experience discussing sexuality, lack of resources, perceived patient discomfort, physician discomfort, and insufficient time. Therefore, physicians should be encouraged to ask all post-pubertal patients if they have any urinary, fecal, or sexual concerns at every clinic visit to foster patient-clinician rapport and alert patients that this is a safe place to discuss their questions and concerns regarding their sexuality. Young women with cloacal anomalies and differences of sex development may undergo vaginal reconstruction to create a patent conduit for menstrual flow and a vagina for sexual intercourse. Mullerian anomalies are very common, affecting 5% to 9% of women with cloacal malformation. A uterine didelphys or full duplication of the uterus, vagina, or both does not affect a woman's fertility, but it increases preterm birth and malpresentation. Needless to say, pregnancies are at high risk for urologic complications in women who have undergone genitourinary reconstruction. Ideally, preconception counseling would help young women with complex congenital urologic disorders make informed decisions about their reproductive health. When they get pregnant, cesarean section is most commonly recommended for women with bladder exstrophy or other conditions where the bladder, neck, and urethra have been reconstructed. The principal aim is to avoid an emergency CS where appropriate urological cover may not be available, as the risks to the fetus and the mother are much higher. Aside from the physico-anatomic issues of children with congenital anomalies, it is also important to understand the difference between pediatric and adult healthcare provision. Pediatric care is described as being patient-centered, with the involvement of different disciplines being focused on the patient, hence the centripetal configuration. Once the patient graduates to the adult world, the responsibility flows in the other direction, or centrifugal, having them go to the different subspecialties without support. The care approach is parent-focused in pediatric care. Clinic visits tend to be longer and access to psychology is more available in pediatric care. Closer and more regular follow-ups are also observed compared to adult care. Previous studies emphasize the necessity of a dedicated adult urologic team in conjunction with a comprehensive team by presenting the altered management that the patients received when they went to transition. Such was described by Chan and colleagues when they presented that 71% of their patients had a change in their bladder management, with 38% undergoing major surgery. A previous report by Watson in 2000 among adolescents and young adults who underwent renal transplantation showed that a third of the patients lost their kidneys in the first 36 months after formal transfer to adult care. This is a frequently quoted landmark study from Sunnybrook, which is by far the largest longitudinal population-based cohort of patients with spina bifida that reports on outcomes following the transition from pediatric to adult care set at 18 years old when they lose access to pediatric institutions. It involves 1,215 individuals with spina bifida who were followed 5 years before and 5 years after they transitioned. From the graph on the top right, There was a 14% increase in the relative rate of ER visits from age 18 to 22 years old compared to age 13 to 17 years old. Concurrently, there was a decrease in the relative rate of hospital admissions. In the graph below, visits to primary care physicians remained stable over the same period, while visits to spina bifida focused specialists decreased after age 18. From this data, the authors were able to suggest that models of transitional care can aim to reduce non-urgent ER visits and facilitate regular specialist care. In terms of ambulatory care utilization, this paper from Michigan that evaluated 382 children over 1 year shows that across all healthcare utilization categories, patients who do not transition have significantly higher utilization of all care compared to those who successfully transition. Taking into consideration all the needs of patients with congenital urologic disorders as discussed in the first part, the hope is that the reason for establishing a smooth transition is conveyed. Because our patients have diverse medical conditions and care needs, their management is also highly heterogeneous. The timing for transition has not been firmly established yet, and while many institutions set a firm deadline by which the process should be completed, such as when the patient is 18 years old, it may need to be individualized and most require a gradual process because an abrupt or quick switch has resulted to unfavorable outcomes for patients and providers, understandable feelings of abandonment for patients and families, and subsequent fragmented care. Transitioning to independent adult care for children who have grown up in a medical environment built around their congenital and childhood genitourinary conditions need to begin early and allow sufficient time for an individual to adapt. Several models for gradual transition have been proposed, such as early introduction of the adult provider alongside the pediatric urologist several years before the targeted time of transition. The goal is to decrease the trepidation of the patient to the new provider, as it may serve as an implicit approval from the long-trusted pediatric urologist. Conversely, the original pediatric urologist may be retained during the transition process or at least should be available during the initial visits to the adult urologist. For patients who have been lost to follow-up for some time or who are moving to a new area, a gradual transition may not be possible. In the last scheme, patients obtained care from emergency or primary care physicians, both of whom are often ill-equipped to deal with the complexity of most adults with congenital urologic abnormalities. Recreating a thorough but succinct medical record for these patients and arranging a telephone conversation between providers to clarify key issues may help to ease an otherwise abrupt transition process. Until now, there is no evidence that any one of these models result in superior healthcare outcomes. Some successful clinics have implemented a structured overlap in care during adolescence, with patients seeing both their pediatric and future adult providers at the same time before the cessation of pediatric care. A systematic review to investigate common themes for an effective transitional medicine program identified overlap clinics as a clear priority in 8 programs. While 3 out of the 4 studies involving a specific young adult clinic within adult services resulted in improved outcomes, only 3 out of the 8 studies involving joint clinics between pediatric and adult physicians did. However, this latter strategy produced improved outcomes in by far the largest study identified involving 1,507 patients, and qualitative research has given support to the concept of creating an overlap clinic with staff from pediatric and adult services, with many young people wanting to meet their adult physician while still under pediatric care. The goal of transition process is to provide uninterrupted care to children as they become adults. These goals are aligned with the triple aim of transition, which are improving the individual experience of healthcare, improving the health of populations, and reducing the per capita cost of care. Establishing routine or regular care aims to promote health, identify and address potential problems early, and avoid deterioration, which is demonstrated by fewer episodic emergency room visits and fewer utilization of healthcare resources of those who successfully transition. A transition team at the Riley Hospital for Children looked at several factors that may predict successful transition, and they found the number of clinic appointments in pediatric clinic over the 3 years leading up to transition is the only factor that showed a trend toward improved transfer, but this did not reach statistical significance. However, it is not clear whether these frequent appointments were due to higher patient compliance or more active issues to be addressed around the time of transition. The other factors analyzed were not associated with successful transition. The study of Hetel and colleagues characterized self-reported barriers to transition among adults with spina bifida patients. These barriers can vary with geographic location and healthcare setting and have been categorized into 3. Those related to the provider, as you can see on the pie graph, those in blue shade, the patient, those in red shade, and the healthcare system on the green portion. In this particular study, physician-related factors accounted for 37%, subdivided into knowledge, communication, and location. The pediatric urologist usually acts as the gatekeeper, but most of them are reluctant to transition at least some of the time, related to lack of a suitable adult care provider to whom referrals can be made. The greatest barrier to transition identified by caregivers was insufficient clinic staffing for care coordination during the transition. As can be visualized in the table, the bulk of the provider factors are communication issues, with the patient saying that the doctor who saw them didn't understand them, so they did not go back. They were not informed that they needed a new doctor, or the doctor just let them go and did not refer them to an adult physician. The physical distance of the provider to the patient's residence is also included here. Other potential, although poorly defined limitations on the provider side include a lack of formalized training, opportunities in adult congenital care, and a lack of financial incentives for providers to care for this patient population. The patient and family level barriers made up 52%, with preference being the largest contributor. 30% verbalized that they feel fine, and 15% expressed some form of healthcare fatigue or they're just tired of seeing doctors. An individual patient's willingness to engage in transition from parent and physician-driven care is a key ingredient to making a successful process. A reluctance to transition has been linked to a close relationship with the pediatric urologist and difficulties parents have with relinquishing parental authority. Factors related to the healthcare system include health insurance in instances when there is lack of insurance, the insurance not being accepted by a specific physician, or certain services or equipment not being covered. In countries without a universal health system, lack of insurance coverage is a significant barrier to the transition of care. Coverage via family or government plans may lapse, and insurance coverage can quickly become unaffordable. This limits the patient's ability to see providers for preventive health visits, forcing them to delay seeking care until problems progress significantly in severity. Transitional care has been an afterthought at most adult hospitals, which renders these facilities poorly equipped to handle the needs of patients with congenital issues. There's also a lack of a dedicated social support system, especially in instances when patients often move away from pediatric hospitals to pursue employment or college without a plan in place for their next steps in care. Geographic centralization of transition services to larger facilities that are often in urban centers may also impair transition despite appearing to offer the best specialist care, as patients often have to navigate large medical complexes, travel from long distances, and use local providers for urgent needs without involving specialty providers. There is also the issue of fragmented care, like the challenge of navigating a new adult system and a lack of a specialized nursing coordinator. What are the core elements of healthcare transition? A well-written transition policy should be properly laid out. Transition preparation should also include education and resources about the transition process, like how to make an appointment and likely contingencies if problems arise, such as when moving to a new state or losing an adult provider. Written material is deemed helpful by the majority of transitioning adults. Nurse educators and sometimes the care coordinator can play an important patient and family education role. Transition readiness, human resources, infrastructures, and equipments are also requirements. Lastly, measures to evaluate the transition process should be established. In a more comprehensive sense, a successful transition needs to be timely, meaning it occurs within a set length of time after discharge from a pediatric provider. It should be lasting, meaning it consists of several appointments during a set length of time and associated with increased independent self-care, which means that there should be limited reliance on caregivers. Validated quality of life questionnaires are useful in determining the impact of transitional urology clinics on improving patients' daily function. The Transition Readiness Assessment Questionnaire or TRAC is a validated survey from Boston Children's Hospital that addresses a patient's readiness for transition to an adult healthcare context. It was developed to allow self-assessment by youth 14 to 21 years old on the management of their health and healthcare. The TRAC questionnaire was utilized in the 6 articles included in a systematic review to assess patient-reported readiness and experience following care in a transitional urology clinic. The main findings of the review were as follows. The range of TRAC scores reported among the available studies was between 3 and 4, which is considered to be in the learning process and started the transition. The identified factors associated with better readiness are health literacy, parental or family awareness of the transition process, older age, and a history of prior stone formation. 77 to 85% of patients were satisfied or felt that the existing transitional care was beneficial and would recommend it to other adolescents with similar conditions. However, fertility and sexual counseling were insufficient. Other assessment tools utilized by other studies are JAX-HATS, ICF for spina bifida patients, Care Transition Measure 15 or CTM-15, and the Transition Care Experience Questionnaire or TCE. To be successful, programs require a team of dedicated providers willing to work closely with these patients and their families during the period of transition. A transition team may consist of as few or as many members as is deemed necessary based on local service arrangements. This is an example of a core transition team, and it might include a lead clinician who will have full knowledge and understanding of the background diagnosis, treatment received to date, ongoing problems and challenges, and future care needs. The lead clinician may be a pediatric urologist if the primary disability experienced by the patient is urologic, but for multi-system disease, it is best to have a primary care provider in this role. A specialist nurse, nurse practitioner, or other specialist physician extender should be present at the transition clinic appointments to be integral in care planning for each young person and serve as the first-line provider in urgent or chronic ongoing healthcare needs as they arise. A transition coordinator is someone who plays an important role in keeping transition planning moving ahead at an appropriate pace. This is especially important in some larger pediatric hospitals where transition care occurs across multiple specialties, ensuring that appointments are made at convenient times for the young person and their family to minimize wasted hospital resources through missed appointments and to maximize the effectiveness of the transition process. A clerical secretary or administrative assistant who works closely with the lead clinician, specialist nurse, and transition coordinator. Lastly, a community service coordinator or social worker who offers enormous support and may serve to help the patient and family navigate the often disjointed community and health services agencies that they often face after the patient graduates from pediatric care. The social worker also assists with the establishment or maintenance of insurance, which was once identified as the primary issue for loss to follow up. The systems required for a successful transition are funding, facilities, and infrastructure. It has been mentioned in several encounters that multidisciplinary clinics are not profitable ventures. Financial viability may require innovative partnerships between providers, philanthropic organizations, patients and patient advocates, insurance providers, and government agencies. Space that accommodates multiple providers, special needs of patients, and equipments for therapists on site. There should be a nearby or on-site imaging facility and laboratory. Ideally, there would be a reserved radiology slots for routine follow-up imaging such as renal ultrasounds and brain MRI. As telemedicine becomes more sophisticated, those developing multidisciplinary clinics may consider installing telemedicine suites to provide remote care to patients with transportation issues. Conferences or other opportunities for sharing interdisciplinary knowledge should also be built into the multidisciplinary clinic schedule. There are several transitional urology clinics or models that have been described in previous studies. This is the REACH transition program established at, This is the REACH transition program established at the University of Oklahoma Health Science Center. The clinic implements a formalized T-staging framework to facilitate the migration of adolescents and young adults to the adult health setting. For the patient to progress from one stage to another, patients are required to accomplish a transition readiness assessment, which is a 12-question survey and is evaluated by the social worker to assess the patient's self-care perception and present independence in healthcare practices. When they reach graduation at T4, the patients are asked to answer a transition satisfaction survey to evaluate the patient's experience and perception of the transition process. Only 42.9% stated being prepared to be seen by their adult urologic specialist. Furthermore, 26.7% opted for earlier and additional information on their adult providers. The study recommended that to improve long-term care for transitioning neurogenic patients, communication between pediatric and adult specialists is needed, social work and research are essential, and the establishment of a transition clinic fellowship as well as education of the provider should be initiated. This is an evaluation of a transition protocol for adolescents with chronic bladder conditions from the Netherlands. The results of their survey were compared to the results of a study in 2010 when there was no transitional protocol established yet. Their urology department implemented a brochure about personal transition care, an individual transition plan, a transition coordinator, and transition clinic. From the age of 12 years, patients receive a questionnaire asking about their knowledge of their condition, their wishes about which subjects they would like to discuss during the consultation, and the timing of transfer to adult care. The study concluded that in the age of 18 to 35 years, the adolescents seemed better prepared for the transfer compared to the situation in 2010. Most of the adolescents were pleased with the current individual transition protocol. Because of the trust in their pediatric urologist, most of the adolescents did not wish to transfer to adult urologists at the age of 18 years. The current clinic does not have a strict age for the actual transfer. The timing of transfer to adult care is decided on consultation with the patient and can take place from the age of 16 up to 25 years. In this specific group, tailor-made transition care seemed to be the best option. This study by Shalabi and colleagues assessed their adolescent transition urology clinic. This one was established in 2009. In this analysis, almost 3/4 of patients thought that written information would have been a useful adjunct, which led the authors to prepare a transition brochure with general information available in the transition process. The value of written information after clinic consultation has not been highlighted in previous reports, but seems to be a useful supplement that might facilitate the complex transition process. This is particularly important as 16% of the patients attending the clinic thought that they did not have all the information they needed to be able to take care of themselves, and 11% were not confident that they could take care of their health. This is a urology transition clinic setup at the University of Virginia. The clinic was established in 2012 and is held monthly. Following individualized assessment of readiness and preparatory discussion in the pediatric setting, established pediatric urology patients 18 years or older with one or more chronic urologic conditions are invited to follow up in the clinic. 1-hour blocks are reserved for each patient. Visits are attended by both the pediatric and adult urology faculty for joint assessment, personalized introduction, and coordinated counsel. In this paper, 99 patients with an average age of 22.4 years were identified as having chronic congenital and childhood-acquired diagnosis requiring urology care. At the end of 5 years, 40.4% had successfully transitioned to adult care, while 59.6% continued care with pediatric urology. Successfully transitioned patients were defined by the graduation criteria as shown in Table 1 on the slide. In 2021, a series of surveys were conducted among all urology residency program directors in the US to identify institutions with a dedicated transitional urology clinic. 26% of the respondents, or 13 out of the 50 hospitals, have a dedicated transitional urology clinic and were more likely to have pediatric and adult hospitals in the same or contiguous buildings or within 1/2 mile or 10 city blocks, and have accredited fellowships in female pelvic medicine, reconstructive surgery, and pediatric urology. Out of the 13 transitional urology clinics, 8 responded to a second survey where they were asked about the number of hours the clinic is run, the age of transition, the type of cases seen, the capability to perform urodynamic studies, and specialty providers present, among others. The main point is that there is a significant diversity in how these clinics are run and staffed, indicating that a lack of consensus exists even among dedicated transitional urology clinics at academic centers in the US. This lack of standardization was evidenced by the substantial variability in provider subspecialty type and availability seen on the graph. There are other published and unpublished transitional urology clinics and protocols around the globe, but overall, the successful transition rate was found to be 59.6 to 87% in different centers. It should be noted, however, that the definition of success is different among these papers. Some recommendations have been recently published by international organizations to provide consensus in the care of these patients. So, the ICCS, or the International Children's Continence Society, came up with this position statement in 2016. The appendix part of this manuscript is particularly important as it discusses specific care requirements in adolescence and adulthood, which are divided into renal, urologic, andrological, gynecological, and obstetric care. The AUA, on the other hand, generated recommendations related to the management of pregnancy in a young woman with bladder exstrophy and one with reflux nephropathy, as well as a young man with spina bifida with CKD seeking undiversion. There is currently no physical transitional urology clinic yet in BC, but you are actually in the process of establishing one under the leadership of Dr. Goldenberg, who is responsible for leading the fundraising and the support from the department led by Dr. Gleave and the continued advocacy from Pediatric Urology led by Dr. McNeely. Care is still fragmented and there is still no standard pathway of transitioning patients to adult care. Patients are passed on based on available local resources. As an example, the patients from the spinal cord clinic are being referred to Blossom Spinal Cord Center or ICORD at the moment if they meet certain criteria, with the physiatrist physicians being the medical leads of their care. As it stands, patients from BC Children's are transferred to adult care providers when they reach 17 years old. The aim of the transition clinic is to familiarize patients and families with the inevitable changes via an overlap of 3 years from age 15 to 17, where care is done in both the pediatric system and transition to adult care clinic. From 17 years of age onwards, patients are expected to see adult providers such as family doctors, adult medical or surgical specialists, but they have support from a nurse navigator and social worker until the age of 25 who can help with care coordination, resources that they may access, or government tax benefits or subsidies to help with travel or missed income due to needing care. The transition clinic will also have a joint pediatric and adult urologist for select cases to help with continuity of care and clinical management for the most complex patients from a medical or surgical standpoint. It would be a resource for other healthcare providers to discuss patient-specific management strategies, treatment goals, and patient information. The clinic, being housed at VCH, will share the same EMR as the pediatric system, which will hopefully enable transfer of accurate medical information relating to the patient. The hope in the end of all of this is for a seamless healthcare journey for the patient during this time. Although a lot of progress has been made in the field of transitional urology, further studies are still warranted. Most early studies involving institutions planning to set up a transitional urology clinic center around markers of healthcare use 3 years before and 3 years after transition. A similar focus is encouraged for institutions that have yet to initiate their transition protocols. Current research are based on small series that are single institution only, with a lack of centralized reporting. Once a standardized system of reporting success in transition has been established, it is worthwhile to compare transition rates among different institutions and healthcare systems. It is also worthwhile to evaluate each clinic's impact on long-term follow-up, clinical outcomes, and patient satisfaction. In summary, there is an upsurge in developments in congenital lifelong urology over the recent years as more urologists and other specialties recognize its importance, and barriers and facilitators for successful transition are identified. Standardized tools to assess and report success of transitional urology clinics are beneficial in the creation of written healthcare transition plan. And as a recommendation, all local hospital administration should be informed of the presence of these transitional urology clinics to reduce the duration between the last pediatric urological visit and transitional urology visit. At this point, I would like to extend a very big gratitude to my mentors at BC Children's, who are also the people leading the planning for Transitional Urology Center in BC. Dr. McNeely, Dr. Cruz Afshar, and Dr. De Los Reyes, to whom I got almost all of the slides for the updates in transitional urology in BC. Thank you for the valuable inputs for this topic. I think that would be all from me.